Very good evening, my beloved colleagues. We are pleased to have you all together here. It's my pleasure. Myself, Dr. Musman Ghani, is welcoming you today. Anyway, so proceed on now. This is our institute. Those who are new to us, this is for them. And some of you are not new, I understand. Interestingly, our topic today is though I told that it may be the very beginner's issue, even then, I know in the last few months or years experience, rather to say, those who are prepared for the exam, I found them. There are some deficiencies in the basics. And the main theme of the exam, a significant number of candidates don't know. So this is our pleasure. It is our endeavor to let you know as much as possible today. Let us see how much we can go on now. So all of you know that the MRCGP Part 2 means OSCE. And we will be busy mainly today with the structure of MRCGP International or South Asian pattern. So this is a very brief, I think only few may be remaining don't know if, I don't know, I hope that all of you already passed your AKT, even then those who are very newer guests here, for your information. In the OSCE exam, there are 14 stations. The target is the clinical and the communication skills. Remember this word, clinical and communication skills. Not very basic sciences, not very pathogenesis and others. Even the pathology, too much detail of microbiology, almost no. As a doctor, as a general physician, what I have to know and how I can make a very good management plan. This is the target. So this is the first information. The structure of the examination in the each station, I told you the 14 stations. In between, there may be 3 or 4 break is of each station like 10-minute break, 3 to 4 in the 14 cycle carousel. And each station you will be given 10 minutes time. After the 8 minutes, you will hear the alarm that 2 minutes left. That means you need to conclude your talk. So I will detail a little more later how to do it better. And before entering the station, there will be 1 minute waiting time to read the instruction, usually in the doorstep initially. And the inside, when you go, you will find that examiners are passive. They will not have any active participation. They will not ask you any question. So this is a picture of exam inside. These are the stations, suppose 3, 4 like that. This is the waiting area. That means the, not waiting, no, actually this is the rest station. There will be 10-minute rest will be there, like another station. Water, there are glasses there. But the alert is that better not to drink more water. It will create maybe desire to void the bladder, then you may be in the risk of timing. Better not to drink more water. This is a suggestion. You see, there is another, the rest station here. Station means just you will be given in the chair and the table is small one. You will be waiting for the next station. This is, you see, these are the stations one, and I like to show you now one inside how the station is designed. You see, she's the examiner, and you, that means you're the candidate, and here is the patient. So the patient to examiner, there some eye-to-eye contact, sometimes by the body language, examiners sometimes guide this surrogate if anything to be guided further or correct further. And the left side, you see there are tables, water for them, and there are some instruments are there. Almost, this is a tray containing instruments. There may be some ECG and others, or any in lab report also could be there. And this is the bed. All the station don't need the patient to be examined. Mostly you need to talk more. And important thing is that whenever an instrument is there and it is related with your consultation topic, remember that you need to use it. That means you need to use the device. So I will show you almost a complete device list to you. What devices you need to be oriented for examination. Any device you need to use in the exam. So this is like this total 14 OSCE stations. So with extra 3 or 4, suppose there is 18 station. So it will be finished 180-minute plus some maybe 18 extra. So around 200 minutes you need to spend there. So you need to be ready for in one carousel of 200 minutes to be stable and competent. And the main message is the content of the exam reflects contextual aspects. Contextual aspects means, suppose a patient from the UK, culturally, they are not oriented like South Asian or even the Middle East country peoples. So till now, the Middle East is covered in the international MRCGP group, and some Middle East country arrange their own examination, but in South Asian examination is more popular, and Middle East country colleagues are appearing there in currently OSCE in the Pakistan and the Sri Lanka. So they base on our local South Asian perspective, the common disease in the South Asian people, common cultural beliefs and others, we need to consider it. And especially those who are from the Middle East country, my request is that you try to be oriented with the cultural issues, expressions, a little. I'm not telling in depth, but simple thing. You need to be oriented with the colleagues or in a group discussion. And the Royal College believe, and they are actually trying much to make the quality of MRCGP, South Asian or the international, is equivalent to the standard of MRCGP UK. So nobody should think that, okay, it is an outside UK examination, it may be softer or maybe not much competent exam, not like that. They're very serious about that. So you will feel great also by doing this. Now, I will show you how the instructions are given in the exam. In our analysis, we found 3 types of instructions are there. That means instruction means the whole scenario be given. I will show you later on few examples, but the tasking, what is your task? After getting the instruction, patient name, age, and others, finally, your task will be in 3 main categories. Number 1, consult, examine, and plan management. In the most systemic cases, means suppose a diagnostic case, maybe coronary syndrome, or diabetes patient, hypertensive patient, chronic kidney disease, so and so on. So you need to talk to the patient, you need to examine the patient, and you need to do a very good, practical, feasible management plan in a mutual understanding manner, not one-way direction. In the second instruction, you find that consult and management plan, planning the management. So examination not mentioned here. In the third one, consult, no examination directly expressed here. Plan management. So I've given in the right side some possible selection of the cases for such instruction. Suppose in the initial diagnostic case, suppose in thyroid illness, Graves' disease or hypothyroidism, definitely you will talk, you will examine, you will investigate. The management, actually investigation and other everything covered under the headline of management. But here what you will do, suppose obstetrics and gynecology, psychiatric patient, they don't need examination, especially psychiatric, very few examination needed. If you think that examination can give you extra information, then you can go for the examination. Here also, obstetrics and gynecology, and you can understand that these are maybe very, very private part examination. Usually they will not allow, but If you want to do it, you will say that I want to examine the back passage, I want to examine the private part. Then the surrogate or examiner will tell you the findings. But in the clinical cases, I mean the chronic disease and other, you need to do some examination, chest examination, precordium examination, or other part joint examination. This will be mandatory here. But in this instruction, it is a plus minus. If you don't need, you feel that I don't need to examine from the history, I'm confident about diagnosis and further management plan, then you can go to the investigation plan and the further management issues. But here, whenever no examination needed, if you want to do examination, it will be your discredit, because examiner will think that actually you were not attentive to the instruction before. So take care of this. I find in my previous colleagues, those who are practicing with me, if they become a little distracted from the session, they forgot to do, and they're telling that, can I examine you? Can I examine you? This is my experience. So I like to focus it on that. Be careful about the instruction. Instruction, rather, I like to say the task, your task. What is your task? Very important. And usually this type of instruction given in the pediatric case, that means the child patient. Child will be the proxy case. I will come to discuss a little later. The counseling, preventive medicine, breaking bad news, in some time the angry patient also there. So basically, there are three basic types of the instructions given to you. Anyway, again, I am reminding you that, doctor, if you think any query, immediately you can raise your hand. I can stop in a suitable time, doctor. I will give a pause. So better not to keep thing deposited in your hand to discuss later on. You can ask me in between talk also. I know where I have to stop. So now come to one example of the instruction. You see, consult, examine, and plan management type of instruction. So Mr. Hussain Jafri, if anybody feel better to read it, to help me also, who will not mind, can you raise the hand please to read it, read the instruction, so that you can remember minimum one case. Can anybody please, can you raise your hand so that I can give you the mic to talk? Dr. Aida? Dr. Zohal here. Thank you, Dr. Zohal. Please read the instruction, please.
Mr. Hussein Jafari, age 55. Mr. Jafari, a truck driver, presented to talk to you about his palpitation. His blood pressure is 120/75, and pulse rate is 110. Proceed with consultation, perform relevant clinical examination, and make management plan.
Thank you, doctor. Thank you very much. So everybody can feel free, doctor, to talk to me, no problem. So this is the instruction. You understand that a truck driver will be an important issue. I am not here to detail everything. He's waiting to talk to you, and he has palpitation. So apparently it could be a cardiovascular patient. So you need to examine the cardiovascular system from pulse. Pulse already given. The tricky thing will be that will you check the rhythm or not? Then this will be tricks. In your practice session, you will remember it and you will understand. Only rate is given. So some hidden issues are there. Could be atrial fibrillation. So if you don't check the rhythm, then you will be in problem. So this information truck driver will be related with the ethical, not ethical, rather so the legal issue. But I like to show you that how the instruction is organized, the consultation, perform clinical exam, relevant clinical examination, not routine, remember. The examination target will be related with the history. History means the presenting problem, not each and everything you need to examine. Finally, a management plan. Further investigation or admission in the hospital like that. Hello, am I audible to you? Sorry for interruption. Dr. Aida, please Is my voice audible to you?
Yes, yes. Now
Okay,
it's
thank you,
okay.
thank you, thank you, please. But actually, I like to show you. You see that this truck driver issue and other I discussed. And so if I jump to the another headline, that is another type of instruction here. Consult and plan management. So this is Mrs. Priyanka Das, aged 60. She's presented to you with the problems of the leaking urine, that means incontinence. Blood pressure given, pulse given. Proceed with consultation and make a management plan. So if you think that you need to examine the private part per vaginal examination, you can approach, but you will not be allowed to examine. This is the fact, and examiner and surrogate will give you the findings. In my suggestion, in my previous course mates and others who were with us before, in practical situation, you like to approach the examination. Though it is not written that consult, plan management, examination to be done or not mentioned, but in real need, you try to approach. You try to approach to examine the patient. So now, the third category is the consult, no examination, plan management. No examination means examination is not needed. Then this one, you can see that Mrs. Jasmine Shah, aged 50. She has deranged liver function test, maybe done by herself or somebody advised. Diabetic patient. This is the report. You see, proceed with consultation, make a management plan. There is a BMI 33. You can guess some probable diagnosis here. Examination not needed here, it is mentioned. Suppose a liver function test, you may do abdominal examination to palpate the liver, or you may see the jaundice, but it is not allowed. So be careful of such instruction. And main agenda here will be the investigation report first. Suppose she's a patient of diabetes. You may have every intention of asking, what about your sugar level? Do you have any complication or other many things? It is not the main target here. We need to understand the flavor of the instruction. Main target, patient main issue, main expectation that you will explain the report first. Then the second round discussion will come. The patient will ask you, Doctor, what can I do now? So you need to give some investigation, further needed investigation plan or the referral, or if you want to give treatment, you can treat the patient by giving some medication and other. But before giving the medication, you need to know drug allergy or any other vaccination status, everything. So I will show you how to organize the overall everything in the coming slides later. But my attention to tell you, you will not examine the patient during the consultation also. You need to focus these investigation first. If you take history 6 minutes, 8 minutes, 8 minutes are over, and finally you are getting only 2 or 3 minutes. There are many things will be remaining. So this is in our sense how we organized our course before. We said that these are investigation report station simply, and how to proceed with. You can hear our YouTube videos and others also. You can understand. So these are the 3 things, doctor, for your better understanding. I hope that you understood what are the types of tasking. Now in the management part, we need to consider the 7 principles. And you see 1, 2, 3, 4, 5, 6, 7. So linking the health belief to the therapeutic plan, and I think if you need, you can raise the hand to ask me further the basic headline. So this is not only giving the medication. There will be what I say, the investigation, social issue, and lastly, it is called the opportunistic health promotion. Though I have written a little shortly, it is said as opportunistic health promotion. But all are not health promotion. Suppose the smoking is directly related with the cardiovascular health. So talking about the smoking is not opportunistic here. But you are dealing a patient of something else, suppose a thyroid disorder or other. There is no direct relation with the smoking. But as a doctor, as a family physician, I need to ask minimum alcoholism and the smoking habit. But time should be there. Time should be there. Again, it is a matter of skill. please wait. And if I go to the end, I will tell you how to manage your time. So these are the headlines. I think you understood. Again, doctor, don't feel shy if you need to ask me anything here by raising your hand. Number 2 point I like to say, it's interesting. Don't be judgmental. Don't be judgmental mean that during explanation phase of the patient, suppose the patient having the lung cancer or COPD rather, not lung cancer, COPD, chronic obstructive pulmonary disease, and the patient is a smoker. So smoking is actually a risk factor, not the etiology. Smoking is not directly related with the effect as a cause. So rather we are telling the risk factor for the COPD is smoking. So smoking is a bad behavior. So when we explain, we will not communicate with the patient in a very rough manner or a judgmental manner that you have you smoked a lot in your last many years, further you develop the lung disease. Or sometimes we say very badly also, you must suffer if you smoke more, like that. No, it is not expected from the professional's point of view. We may say that as you smoked before, possibly for that you have developed this disease. It will be the way of communication. So don't be judgmental that it is you have this behavior, for that it is happened. This is called don't be judgmental. And number 4 point, doctor, you see 3E model. During explanation, we need to follow 3E model. First E is the exploration. That when you talk about any disease, when you give any management plan, everywhere the 3E model is important. First, explore how much patient knows. Suppose you are treating an asthma patient. We need to teach the patient how to take the inhaler. But I don't know how much he or she knows about the inhaler technique. So first ask that how much you know about the inhaler, and do you know how to take it? Please show me. When patient shown to you, the inhaler technique shown to you, then you take your floor to explain further. So this is the second E. So first is the explore, second is the explain. You will explain or you will show how to do it. Finally, a feedback. It is the third E. It is called the final exploration. How patient understood from your talk or from your demonstration. So it should be maintained, but in the OSCE, actually, time is very short. In the last exploration, we try to cover in a manner by asking the patient that, is it okay? Is it okay in this manner? So otherwise, safety netting here, safety netting means when a follow-up plan will be there as a home management plan, patient will come back maybe after 2 weeks or 1 month. In the meantime, if anything happened wrong, where to communicate by the patient? To you or to the emergency department or directly to the hospital? Safety netting. Second thing, not to respond, rather patient can handle his or her situation sometime and how to do it. This advice is called safety netting, is very, very special in MRCGP or family medicine exam. So try to remember it. And if go to the structured consultation, so consultation plan should include data gathering. After the data gathering, you need to formulate probable diagnosis, differential diagnosis, other routine questions I will show you. And after this questioning, you will make a problem list. Traditionally, we know that what is the diagnosis. Actually, in family medicine, only diagnosis is not sufficient. Suppose a patient have diabetes. Traditionally, we say that my diagnosis is, this is a case of diabetes. But in the family medicine, trending is that we need to say by the name of the patient, Mr. Karim has diabetes. That means we are focusing the patient or the person first. Then the third one, that this is the disease. It is a biologic problem, diabetes. Suppose hypertension is a biologic problem. So diagnosis basically consists of 3 parameters, 3 dimensions: social, psychological, and biologic. That means the mental status also important, social status also important in the diagnostic. So it is called the triple diagnosis. Plus, if patient does not have money, it's a social problem. Patient have some issues to talk to you, maybe beyond the medical science. It may be also problem list. We may solve or may not solve. This is the later issue. So we need to write a problem list one by one. Even patient ask you some idea, concern, expectation, very relevant thing he may ask you. It is also issue. Okay. After listing the problem, then we will come to the management plan one by one. So basically, these are the main headlines. Now, I'm showing you how to structureize this thing. Data gathering, the basic weapon, you understand, history and examination. And then select the probable differential diagnosis. Very often I found that after taking the history and the examination, doctors are telling that I like to do some investigation, or suppose I like to do some test now. There are some jargon, doctor. It is not the time to tell you the details of the jargon. We will not tell you investigation. We will tell that I like to do some test. But this is very traditional and the clinical method in our real life also. We take the history, we examine the patient in the chamber, keeping some differential diagnosis in our mind, then we formulate the investigation. Maybe we are very, very far away from the diagnosis, but as a doctor, we may think something. For that, after explanation to the patient that I am thinking you may have this 4 or 5 possibilities even. Do you understand, or is it okay? Is it okay? After understanding, then tell that I like to do some test to be more sure, or for your further management, or to tell you or answer your this question. So investigation plan. In the exam, some investigation reports are said by the examiner or the surrogate. Wherever you say that CBC is there, as a CBC is a very universal investigation, but the findings are not there in the CBC. That means CBC will not be too much informative for your patient. Usually surrogate may be silent. Whenever you say that I like to do blood sugar, because you are thinking that patient might have diabetes, then surrogate will tell that blood sugar fasting is, suppose in the millimole, 12 millimole, postprandial 16 millimole, they will tell you. Suppose you are thinking that the diagnosis for the hyperthyroidism, whenever you say that I like to test the thyroid, blood test for the thyroid, it is not a thyroid function test, better to say the layman word, the test for the thyroid or thyroid test to the patient, then patient means surrogate, or the examiner can give you the findings if it is a diagnostic for the thyroid, or there may be differential possibility, examiner will tell you that thyroid function test normal. So this is the way. It's a game or matter of practice rather, matter of orientation. Exam is a matter of orientation. So these are very diagnostic thing. Now come to the other routine. We must not forget it. Drug allergy, vaccination issue. If the female, feel pregnancy period, and if it's a child, bind, B-I-N-D, and the elderly, 3 ID. There are 4 points. There are 5 points for the child. I think I can show you maybe there in the right column after finishing this box. Problem list. I told you before, after getting everything, you will write a problem list. Now, how to write? And I found that interestingly, many colleagues confused until I get them in our practice. They don't know that you are allowed to write on the table, like your prescription. Inside the room, a pen will be with you. There is a paper, A4 size paper, maybe with a support. In the real life, I am talking to the patient, I am writing in the paper, that is the prescription. So in the exam, you will not write detailed prescription, but you will write some points, especially the problem list, one by one, maybe 4, 5, 6 points will be there. That means you like to answer all of the points of the problem. Okay. In the problem list, especially this should not be forgotten. Diagnosis, possible etiology, complication, and the comorbidity. If there, suppose a patient have ischemic heart disease, so might have comorbidity, the diabetes or dyslipidemia or hypertension, even the smoking, the bad health behavior also, it is also problem list. That means we need to talk about how to quit the smoking. So if you don't write in the stressful situation, even not as stressful, in real life also we may forget. So write in the paper inside the 5 or 6 problem list. Okay. So minimum, I believe that minimum 5 problem lists you may get in the station. Little there. So you need to address it, including the idea, concern, expectation, impact in daily life, social life. There may be some hidden agenda. I told you just before a few minutes that pulse rate is given, but patient is heart patient, palpitation, but we are only counting the rate, given the rate. So what will be the hidden examination issue? Rhythm of the pulse. So this is the test. This is the focus examination. Focus. Any ethical and the legal issue will be there. If write whole problem list, then come to the management plan one by one. Explain diagnosis. That means after getting the investigation report, you become confident almost. But your probable diagnosis you can see here before investigation plan. But after investigation, you are confident. Then you are telling explanation, not the repetition of the words before. In a different extra information you like to say, you can say here. Then decide, will you refer to any clinic, specialist clinic? Very often I found that our colleagues are telling that I will send to the heart specialist, kidney specialist. My humble suggestion to you, the specialist is a person, but if you refer the patient to the clinic, is a whole approach will be there. The concept of patient management is the holistic approach. So we need to send to the clinic, suppose high blood pressure clinic, sugar clinic, elderly clinic, memory clinic, fertility clinic, maternity clinic. It would be good fit for family medicine background. And hospitalization, if you think that today patient needs hospitalization, in the hospitalization also, there are some categories. Categories means immediate hospitalization, that means within minutes and hours, or same day hospitalization, or as a routine referral or planning for the hospitalization, maybe in the 1 week or 2 weeks, you need to consider it. Or you are not doing anything, just OPD follow-up for you. You advise some investigation, then patient will come back to see you. Or after the treatment, after 2 weeks or 1 month, patient will come back to see you. So this investigation, the referral hospitalization, the OPD, or any special referral needed, you can send there. Okay. Then the safety netting, I already described before, how to do the safety netting. And finally, after the diagnosis, we will give medicine definitely there, but never forget the non-pharmacologic treatment. Health education. This is more important than medication in the family medicine background. So lifestyle and other, even I told you, smoking is not directly related with your consultation. When you get the patient is a smoker, to come here to say about the smoking issue here, motivate him or her. Any driving and flying is important, especially driving must not be missed. Suppose a patient of epilepsy, invariably driving is important. So you should not miss the driving issue. And lastly, I told you opportunistic health promotion, already I described. So this is very, very important chart, doctor. If my request, be attentive with this. If you don't understand any point here, immediately, please, you can raise your hand. And the bind and other, I like to show you now. Suppose for the baby P bind, the BIND, yes, Dr. Karishma, you just wait 1 minute. I'm finishing this, then I will give you the mic. Keep your hand raising, doctor. Bind is the birth history, how delivery is done, immunization status, nutritional status, and the development. You know, the milestones of the baby's growth. There are some layman terms how to ask. I will not tell now today. But my intention, personal intention here to add one P. For that, I have written is P because internationally, some books you will find the bind. I didn't find anywhere P is added. P means pregnancy. And I got the experience. And if you go through the book also, you will find that if the baby in the pregnancy of the mother time have suffered something, suppose mother suffers some disease, after the birth, baby also may develop some consequence. For that, in the routine, my suggestion, we need to ask 5 questions regarding a pediatric patient. Now, the second one is the elderly 3ID. This is our own customized mnemonic. 3I means immobility, instability, incontinence, and the dementia. It means if patient, elderly patient, geriatric patient presented to you with the dementia, as a routine, you will ask 3 questions. Or even no presentation with anyone here, but your patient is 65 years, 70 years. There might be something there, but patient is not presenting because patient have some other issues. So as a routine question in elderly patient, 4 questions. In the pediatric patient, 5 questions you need to ask. So after this, I think we are going to Dr. Karishma, please. Your mic is open now. You can unmute, please.
Good evening,
Doctor.
sir.
Good evening. Please.
Sir, in the safety netting, we can give them like if it is, we know that patient will be in serious condition or maybe had further attacks or like this. We can tell them to, if you had this attack again, you can call the ambulance. These things come in safety netting?
Definitely. For the patient safety.
Or you had this problems, you can go to emergency departments.
These
or
are
some
the
leaflet.
safety netting. Yeah. Leaflet can help you. I will come to the leaflet issue later, in the management part, a little later. But patient have, you advise, or patient is on insulin treatment, every chance that patient may develop hypoglycemia. Okay?
Yes.
So if hypoglycemia is there, where will patient go? Rather, patient will drink the sweet drink immediately, right?
Yes.
If the things are settled, then patient will go to you or the emergency. So this is also safety netting. Even any drug you have given, possibly patient may develop the side effects of the drug. I will alarm the patient after taking this medicine, you may have this problem. Then what you will do? You will stop the medicine and come to me or come anywhere or go anywhere. All the things are safety netting. Very good question, Dr. Karishma. Thank you to revise it. It is very important. It is very special in the MRCGP. Fine. Thank you. Any further, doctor?
Thank you, sir. Thank you.
Well, any other colleague, please? It is your time. Few seconds. If you have, please raise your hand. I think no more. Okay. You are very intelligent, talented. And my voice is enough for you. Very good. So, if you make an consultation steps, this is our production, rather to say, we customize it from our institute. It is, we try to make it very universal chart, not only for the family medicine, even in the PACES exam, any clinical exam. Everything you will get here in the small, concise manner, but every one headline will take more time to be detailed. I'm just trying my best, very simply, very short time. Greet and meet. Mr. Karim, good morning. I am Dr. Haq. How can I help you? I am Dr. Karishma. How can I help you? This is very simple thing to start. There are some body language and others. How can I help you? Patient will tell you the presenting complaint. But usually, I find in the OSCE exam experience, a little different than other exam. How? Suppose I can compare the PACES exam because I am oriented with this. I think all of you know. In the PACES exam, suppose patient tell only the one symptom or instruction given with the one symptom. So you will be busy with the symptom. But in the OSCE, patient can tell you some information even from the investigation. Patient can tell you their idea, concern, expectation in the very early. Suppose patient can tell you, Doctor, I am having headache for the last 1 month. Doctor, possibly I have brain tumor. Can you do one scan of my head? So the things are not remaining only with the symptom. You need to remember it. This is the test of your concentration to the patient. So you will actually, there is very less scope to write. You need to be very steady and confident and from the very beginning and remember it. Because in the part of the idea, concern, expectation headline, I have written here though, you must ask it idea, concern, expectation. So as a routine dogmatic presentation or consultation, you will ask that, yes, Mr. Hawk, suppose the patient name, what do you think? What is the reason of your disease? Okay, patient told. Finally, you will tell that, what do you expect from me? But already patient told you that he is thinking brain tumor and he expects that he will do one CT scan, but you are repeating the same thing. Things are like that, you forgot the patient's statement before. So how to overcome it? To remind the patient that, dear Mr. Ha, you told me that you are thinking you are having brain tumor and you want that I will do one scan of the brain or head. That is actually patient meaning the CT scan. This is the way of pulling the information at the real time. So I hope that you understood what I mean. Definitely it needs some practice session also. So these are the steps, doctor, past history. This is not the time, doctor, I'm touching a little. Suppose symptom analysis, onset, progression, duration, character, aggravating, relieving factor, timing of the day. P means the position also, the location of the symptom. Suppose the pain definitely have some location. And if the pain is there, additional radiation is the important. Otherwise, all other symptoms we can explain in this manner by this mnemonic. And then ask other symptom of the relevant system. Suppose patient presented with the palpitation. So palpitation is the cardinal symptom of the cardiology, heart. So after hearing the palpitation, definitely I will ask the central chest pain. I will ask the breathlessness. I will ask the leg pain, the ischemic event. And then general health queries is very, very important. Suppose the red flags are there in the general health query. What are those? The fever, weight loss, anorexia, sleep problem. These are 4 minimum. You can add other issues also, especially the female, maybe the menstrual bleeding and other. So these are 4 health query. If patient presented with the weight loss, definitely I will ask about the fever, anorexia, and the mood and other psychological issue will be there in the mood. So if patient is non-specifically presented, general health queries will be very important for diagnostic clue. Or in general, suppose a patient having loose motion diarrhea for a few weeks. If it is a malignant case, definitely patient has history of the weight loss. So if you don't ask about the weight loss, if patient asks you, doctor, is it a cancer? You cannot give the answer of the patient's question. For that, as a general clue or general health query, routinely better to ask, especially patient have the chronic problem, we must ask general health queries. Everything is a detailed, doctor, that if you want, you can request, I will give you the links. The detail actually written in separate paper, separate file, I will provide you if you are interested. In the past history, you see, the diseases, surgical, medical treatment, blood transfusion, even the investigation data also could be a past history. Drug history can give you the diagnosis. Suppose patient is not telling you patient having dyspepsia. When you take the drug, in South Asian people culture, they tell that, doctor, I'm taking the omeprazole. Why patient is taking omeprazole? That means patient has symptom of dyspepsia, maybe peptic ulcer disease. They forget to tell you. Suppose you ask about that, are you taking any medicine? I'm taking metformin. But actually patient didn't tell you before that he has already diabetes or she has already diabetes. So drug history can give you the diagnostic clue as well as other qualities of the drug, medication, compliance, allergy to the drug, again the immunization. We group the drug, the vaccination in the drug history group so that easy to be remembered. Family history means father, mother, sister, brother, and the son, daughter, health status. Social history, very important in family medicine. Say diet, food, especially any GI symptom, definitely diet. Cardiovascular, diet. So these are directly related. What about your food? What do you take? And the fever patient, travel history, mandatory fever patient. Okay, any private issue, sexual, suppose genital discharge, sexual history must. And the impact of symptom in life. We marked it very red with the red color, must not be missed. So housing, home health, musculoskeletal disease, rheumatologic disease, osteoarthritis, housing, in which floor they stay, is there any lift or not? So family life needed, any support, especially the home health, with whom he is living. Is there any helping person to help the patient? These are important. Idea, concern, expectation, I told a little. And other systemic information. So in OSCE exam, a limited time is there. Other systemic information, detail not needed. If you get the diagnosis here, most of the time you will get the diagnosis in this point. Symptom analysis, other symptoms, general health query. And the past history sometimes give the clue. Family history sometimes give the clue. For that, systemic inquiry, in most of the time, not too much needed, but systemic inquiry needed for other purpose, the complication or other issues may be there, or comorbidity is there for that important. Finally, summarizing the history. In a real science doctor, very few candidate I found that they can summarize the patient because time is very short. If you start to summarize, it may take 2-3 minutes time. So summarization should not be, I like to say, should be less than 1 minute. or even 30 seconds, 40 seconds is very good. If you cannot summarize due to the lack of the time, simply we will tell that I came to know from your story and examination, you are suffering possibly from this. How much you know about this? Okay, this, then I like to do this investigation or the test rather to say. Okay, this is the summarization. Again, if you do the practice, then actually you will get the idea how to summarize. And the last 2 minutes also very important. So this is the talking only part we finished. And this is again repetition to you. After these consultation steps, actually we are identifying these materials, the impact like hidden agenda and other. So this is one way you can make a headline for the history. Suppose 1 point here, history, and this 1 point actually enlarge whole thing. That is the talking, examination, clinical examination, focused examination, then the investigations. So it is additional headline given, drug history and allergy. Actually, it is under the history rather to say. And this is the management plan I described before. And now, how to prepare now for your OSCE exam in a systematic manner? We actually group these systems in this group. The topmost definitely cardiovascular, finally eye disease, ENT disease. These are the list. But in the exam, you know that the patient will not tell you, doctor, I am the symptom from endocrinology. Doctor, I'm having the problem for my heart disease. Not that. Patient will tell you the symptom. You need to identify the diagnosis. But in the OSCE exam, this is the exam of the technique. If we consider the whole system, the case category will be in this manner, around 10 categories. Very significant number of cases will be of the chronic clinical disease, some acute clinical cases, psychosocial issue, legal case, investigation report, proxy case, preventive, promotive, and palliative case, breaking bad news is very extraordinary, ethical case also there, and the miscellaneous. So we tried our best to group into the 10 groups. And for the initiators, those who are thinking to prepare yourself, you need to consider this thing first, because cardiovascular, respiratory disease and other, to practice in the systematic manner will take time. If you don't know the technique of proceeding the chronic clinical case, proceeding with the proxy case, proceeding with the breaking bad news, your preparation will not be strong. For that, what are the, suppose the preventive case, what are the promotive case, how to do breaking bad news. In the miscellaneous, there are some additional cases are there. In the how to tackle the acute case. Suppose I have shown you a big list. The previously, if you don't mind, I'm going back. Suppose this thing, everything needed in a patient of chronic clinical case. But when patient need urgent hospitalization, you should not ask all of the thing. What should be asked, you have to select by yourself. And you need a better prompt action plan. You arrange the patient to send to the coronary care unit or sending to the neurology. You need to organize, even calling the ambulance is your part to do it. So this is a different acute clinical case management. Similarly, I told you the 10 groups are there. Now coming to your few talk on the examination planning, you find that you see the devices will be there. These are called the instrument in medical education language. So the instrument will be there. Some devices will be there. I have highlighted this thing as instrument, but ECG, chest X is very common. Otoscope, ophthalmoscope, they may, or you can approach only the finding be given, because you cannot insert the otoscope in the ear of the patient. Rather, they can show you the clinical picture. Sorry, not clinical, rather finding picture. When you start to see the ear, examiner will tell you, or surrogate will show you a picture of the ear. Suppose ear drum is ruptured. In the ECG, when you say that I like to do one heart tracing, Mr. John, then Mr. John will show you the ECG tracing, then the ECG record. So by looking the ECG, you will be able to diagnose the case. X-ray, in the last exam, possibly X-ray given. That was my forecast maybe 1 year before. I was telling to my colleagues that get ready for the chest X-ray because ECG given. In the last exam, those who given me the feedback, they told me that they faced the chest X-ray there in the exam. So in the coming days, I believe that they will give you some lab data. Suppose a complete blood count report. So you have to be oriented, capable to explain the CBC report to the patient. So these are the things, including the red mark given. That means very chance that you need to do it. Stethoscope use. That means you will auscultate definitely. Reflex hammer will be there. The jacks and others, tuning for visual acuity and the color test, Ishihara chest and other. Peak flow meter, most important device for the asthma patient. So you need to instruct the patient how to use it. These are the very, very important the skill, practical skill you must do. And if you don't know, please you try your best, talk to your colleague, friends, and minimum you can see the YouTube, how to use it. They can guide you. They can guide you. YouTube can guide you a lot. Okay. Still nobody raising the hand. For that, I am proceeding with myself. Now, if I don't know how many time I have taken, sorry, doctor, if I take more time, I hope that it will be useful for you. For that, I'm taking a little more time. Now, I will show you one complete consultation to you, how they are doing. So this is the extract of directly not from your exam, but I feel that the approach by the doctor to the patient will be very, very useful. I will guide you. I will narrate you what they are doing. You just look at the video, doctor, please. If you cannot find it or any trouble, please, you will raise your hand to correct me. Any technical problem there or not. Look at, is the doctor. Dr. Aida, possibly you cannot hear the voice of the video. Am I right? Or anyone, please, Dr. Mammon? Can you connect just to help me? Is the audio of the the video? Can you hear the voice? Sorry, doctor, you just disconnected again. Can you hear the voice if video runs?
No, sir.
No.
We not here.
Sorry,
No.
sorry. This is a limitation. I will narrate. I will just show you how to proceed with the examination. Thank you, doctor. So you see, the doctor is talking. Palpitation, palpitation patient, you see. So is talking to the patient, asking relevant informations. The body language you can understand is a case of palpitation. So you are taking the history. I am proceeding. And how to examine now? Now she will examine the patient. You just follow how she is doing. I hope that you will ask me something after examination. I am waiting. Please, everybody be attentive in the examination process. He is examining the pulses. So he's examining the patient as well as he's asking question also. You see, he's examining the patient and she's asking some question in between. This is the overlapping of the history and examination. It is very, very important to manage your time. Okay. Now look at the precordial examination. So examination finished. Any comment, doctor, from anyone? Any criticism of the examination? Precordium examination? Please, anyone, please feel free. It will be very useful for you if anybody responds my question. Yeah, Dr. Karishma, please.
Sir, this in COVID condition, still we have to shake hands with the patient?
Oh, this is very critical. COVID almost going now, but if COVID resurgence is there, you will be instructed not to shake the hand. But in the last examination, almost the strong what I say, prohibition possibly was not there. So shaking is a relative issue. If they tell you not to shake, don't shake. But any precordium examination, I mean, any comment, doctor, regarding the precordium examination? Dr. Sarah.
Doctor, they try to do precordial examination, not lying down in bed.
Yes, very good idea. Precordium is examined on the bed in the proper position, 45-degree, flexing or extending, whatever you say. But this is our real life situation in the chamber as a family physician. These clinical method usually not followed 100%. This is one observation because the cardiac auscultatory finding, most finding you may get by sitting position in the chair. If you think that you need to see your patient more minutely for getting further, then you can examine over the bed. But in general, you can do it. I'm telling that it is not very badly done, but the most important or better will be if you get your patient lying down on the bed by 45-degree, flexing the bed. If you find that in the exam hall, there is a bed I have shown you in the picture, the bed is already ready 45-degree, then you have to go in. Because the bed is flat, you will raise the bed and there may be danger also. So in the exam hall, it can create awkward situation. So if the bed is ready, you will get your patient, can you lie down on the bed and expose the chest? Usually not done. But it is not there, you can examine. But another things are there. When she auscultating, you see, if the winter season, maybe in the winter cloth also there. What do you think, Dr. Karishma? So you are auscultating, you see over the cloth. Respecting her, maybe the values, social values. Yeah, doctor, you are not connecting, Dr. Karishma.
Yes, sir. Yes.
You see, why you are not telling that this is auscultating over the cloth? So you think that this stethoscope diaphragm is the very, very strong diaphragm, can receive the sounds even from far away? Not like that.
No, yes.
But in real life, we do it. But I think my suggestion to all of you, you can correct yourself. Minimum is young lady, suppose you maintain the privacy. And even you can put your hand under the cloth if you don't like to expose the chest. Okay, doctor? Sorry, you are always disconnected, Dr. Karishma. I don't know, maybe busy.
Yes, sir. Yes. But it's
Connected,
unmuted.
connected. Don't be
Yes.
muted, doctor. Don't be muted by yourself.
But if it is a male patient, sir, we can expose for inspection.
You try your best to expose. If the examiner or surveyor tell you that you can examine over the cloth, then you are free. But in the private part, suppose this young lady is difficult, right? But if you go back for the chest examination, if you expose the back, no problem. You have to consider it. You have to. Second thing, in the traditional cardiovascular examination, inspection, palpation, percussion, auscultation. But we avoid the percussion though. But there are 3 headlines. But you see what doctor has done, only auscultation. And most of the finding, as it is obtained by the auscultation, if you do auscultation, if you can correlate with the history, that's enough. No need to do each and every point of the examination. Because you know, you have to finish everything, including the management for the safety netting within 10 minutes. So remember it. So if you go through the cases, then you will be able to create your own examination plan. One thing I like to repeat, and this doctor also doing, when she is examining, in between she is asking some informations. And you know it, you can do. Suppose you are examining the hand, looking at the hand. In the meantime, you can ask that, do you smoke? Do you drink? But you're looking the fingertip. It can happen. So this is the examination part. Now I'm moving to the next one. To actually grow the skills as a professional, it is said that we need to have, a doctor must have 7 clinical skills. Skill of the physical examination, identifying the physical sign, clinical communications, that is we are conveying the message, differential diagnosis, that means the probable diagnosis and differential diagnosis, the clinical judgment of your diagnosis, clinical judgment of asking further question, clinical judgment for investigation plans. Then the managing patient concerns, important. finally, the maintaining the patient welfare. When you are talking to the patient, it should not hurt the mind or body of the patient. Patient welfare. This seven skill actually will make us the great physician. If even we take the social history, psychology, that means the triple diagnosis, it will be very great. So the great man in our medical science, William Osler, said that the good physician treats disease. Great physician treats the patient who has the disease. That is the message of family medicine, doctor. So after this talk, I like to tell you, try to grow up by yourself with minimum these 7 qualities. Minimum these 7 qualities. So as much as possible, doctor, I tried my best to talk to you. And regarding some other thing, few minutes, doctor, if you want to have our learning material and everything, I am just showing you our group. I am writing in your chat box, doctor, of all of you. If you are not the member here, sorry, doctor, give me a few seconds time. Yeah, copy is there. So you can be with us. Many discussion you may get in the YouTube regarding this thing, not only this exam, it may be in PACES exam as well, or any other competitive exam is useful. So in the chat box, all of you can find the link. If you can click minimum, you can be with us. There are one WhatsApp group, another in the Telegram group. So anyone you can use to be with us directly. Yeah? There are some YouTube also maybe given. Yes, one YouTube link also given. You can see in the YouTube, a lot of things are there. So anyway, so now come to the other issue, doctor, and maybe you don't need the break time. If you want, you can take, but we can proceed with the few minutes. But in the meantime, doctor, I think we can take 1 minute time to give you a chance to raise the question. Can you raise the hand, please, to ask me the question, any relevant issue, what I told just now? If anything confusing, you can ask me, please. The main agenda of the talk is almost over. We have something else, our action plan to share with you. But until now, I have said the basic thing, how you prepare yourself. Possibly, I didn't tell you the last 2 minutes time, how you can utilize. Time is short. I told you that in the 2 minutes time, you need to address minimum 5 or 6 problems. Okay, so how to overcome this time shortage? At that time, you can use the leaflet. Suppose you need to talk about the smoking cessation, but patient of the epilepsy, driving issues are there. So a lot of things are there. You need to say to the patient, you need to ask that, is it okay, checking the understanding. So 2 minutes is not enough. So practically you need to finish within the 7 or 8 minute, the main agenda, and the 8-minute target to finish everything. The extra 2 minutes will be, suppose, your bonus. That means definitely you will enter into that last 2 minutes time. But in practice session, you try to improve your vocabulary of English and try to talk fluently, but not overlapping, clear voice, and try to ask the question in very few words, not a long sentence. I am telling, but not easy to demonstrate. So my suggestion, all of you, as you are planning to prepare for the OSCE, you need to read. Suppose one answer also I like to say. What is your name? You are telling that. Suppose you are asking me, what is your name? I am telling I am Osman Ghani. So now your next question, what is your father's name? You can ask in this manner. But in the second question, you can say that your father. Enough. I understand that you are asking the name of my father. So these are the way, some little skills are there to talk about. Suppose patient asking you, doctor, can I take meat, beef? Answer is very straightforward. No. But what you are doing, you cannot take beef because you have heart disease, other disease, cholesterol. Actually, patient not asking why he cannot take beef. He's asking that, doctor, can I take beef? Can I eat beef? So directly you can answer that yes or no, enough. But you are explaining, because you are explaining, doctor. You know how to explain more and more. But it will be hazardous for you also for the time management purpose. So the last 2 minutes, how to answer very shortly. It is a matter of skill. Dr. Karishma, again, please. Dr. Karishma, you can open the mic, doctor.
Yes, sir, there is problem with this. Sir, in some like OVG cases, if
Yeah.
my diagnosis is ectopic pregnancy, and
Yeah.
I tell, like, I will say, it's not necessary to examine the patient. I will say just, I will examine for the cervical, this motion or cervical tenderness. Like this, we can, if we say just and we don't do it, they will accept
Yes,
that.
definitely.
At
This
least
is
they
the
know this idea is in our head, but for example, like for ectopic pregnancy, for example, this is very important. From one PV,
definitely,
I know that
definitely. You
so
will
only by
must
saying they
say.
will accept.
Yes, doctor. Not only for vaginal examination, you have to examine per abdomen also. Suppose there is a
Yeah.
tenderness in the left lower quadrant. There may be the ruptured ectopic pregnancy. Definitely, you will find the tenderness is there. So there is a patient, actually not patient, they are surrogate, they are actor. But they can minimum produce the tenderness. If you press over the left lower quadrant, then they'll say, oh my God, doctor, I feel pain. They can show. But for vaginal examination, you cannot do. But you will say, I like to examine your private part. Can I? Then they will tell you, yes, for vaginal examination shows whatever you say. Cervical motion, tenderness, fullness in the, the forniches and others.
Fornixes. Yes.
That is the thing. And you understood rightly, doctor. I'm thankful to you that you understood my talk. Likely. Please, any other colleague, any query regarding this? No more maybe, eh? I think all of you know that the session should be finished early. But we have a chance also to leave also, no problem. Anyway, so if we take a few moment, a little more, come to that, how you, some technical point of learning and other. Why the group study is important. I like to tell you now. This is the educational pyramid, the memory retention pyramid. How we empower our brain, how we retain the informations in our brain. It is found that if you hear the lecture only, the memory will be 5% retained only. If you read, 10% retention. If you see, 20% retention. If you see some demonstration, practical demonstration, it will give only 30% retention. So up to this blue color, it is a passive teaching method. Somebody will tell, somebody will show, you can gain up to 30% only. But as a senior doctor, you definitely finish your graduation. Maybe today, some of you have the teacher also in the medical college. What we are teaching our students now, in this manner only, mainly. But some group practical studies are there in the world or somewhere else. But mostly, we are fascinating in our lecture classes. So you see, the lecture means only 5% retention. But it is found in the red color, you see, participatory teaching methods, interaction, teacher and students. It will give 50%, 75% practice by doing, by the hands. And the teacher will get 90% retention. So this is the advantage of the teacher. So group discussion and the practice by doing will give you 50 to 75% memory. So that we are following, doctor, from our institute in the different online groups. That we are creating the group. Some of you possibly know us, and those are new for your kind information. You must be in a group. I'm not meaning that you come with our group. Whatever you are, with whom you are, you maintain your group. Single reading, single study will not be fruitful. This is actually my suggestion. But definitely, we will appreciate, we will feel pleased if you will be with us anytime. So this is the group teaching. For the group, doctor, just if you don't mind, I may take some few minutes, 2 to 3 minutes more to show you. This is the planning. And we develop our candidate in the 3 steps here, 2 or 3 others. First is the very basic regarding the technique of consultation and other. You see, this is our planning with the 9 classes. And we say it how to fish. Talk about the story, fishing and eating. Just to know how to fish. This is the basic thing. We are busy with the different case topics, chronic case, acute case, with this manner. Including in the basic, doctor, we arrange the focus examination technique. The how to make our examination technique focused. And the ECG X-ray fundoscopy session also will be there with some free master classes. But we will cover from all the systems more or less by this type, and maybe one chronic case maybe from one system, acute case from another system. In this manner, we actually mixed up to give you in a short time to give an overall impression of the exam topics. How to fish, we say, and after the how to fish, you will come to the next stage for your preparation. It's going to now do fishing. You learn how to fish, but now we are fishing. That is the system-wise practice. Up to these 14 group, INT and the miscellaneous system-wise cardiovascular respirology. Again, they are the mixing up of the case categories in this system. So our highlight here will be the systems, so that you can cover all the system. Again, it will be actually 1:1 feedback session. Though who has attended, you know it. Usually timing in this time like today. And the final one is the mock practice. Now start eating. After fishing, cook, then eat. Start fishing. So this is the final preparation. This is actually our issue. I don't like to detail more here. In the group, you may know it detail. This is, I tell you that yourself also, if you try to develop in a stepwise fashion. And I find that some busy colleagues are requesting me that they like to do mock practice. But actually, I don't like to encourage them. And in the meantime, some of you communicated with us, and I always, you know, that I like to ask you, what is your situation? When did you pass your AKT? What did you do in the meantime? Did you go any basic courses with anyone? You have to be free and frankly for further guidance of you in the exam. So better not to come to the mock courses directly. My advice, be busy. Those who are especially recently passed your AKT definitely will come to the basic courses. And this is our great message today for you. We are arranging our basic courses very soon, maybe 2-3 days after. I like to highlight that time management is very, very important in the exam. Those who have done, you know, and you will come to know definitely in the OSCE exam. As a doctor, most of the knowledge you have, if you go through the book, you will acquire. But if you cannot provide it, the information by your skill in the exam, what is the value? So under this skill, time management is very, very important. Very, very important, doctor. And this again, to show you, this chart will help you and try to remember it, this chart. And this is the thing, doctor, our whole approach, step 1 and step 2. Already I discussed with you. This will be very 1:1 practice, and in the basic, there will be interaction will be there, and different parts of the communication skills, case details, what are the types of the cases, what may be the hidden agenda. It will be like a group discussion. I told you, I've shown you group discussion, preferably the best method of learning. And this is the feedback session, 1:1. Usually it is a little, I like to say, not too much advanced, a little advanced, doctor. Those are very, very new for the OSCE preparation. I suggest better not to come with this practice. You can be observer as a silent observer, but don't come in the direct active slot. And interestingly, our active slot is finished in coming days. From tomorrow, it will be started. Anybody want middle category or prepared? You can come to the only with the coming batch with the silent as a silent participant. But for the basic, already we opened it. Registration already done. And this is, I have shown you possibly this thing. This thing I've shown you YouTube and other. In the YouTube, you'll find many, many videos in the headline shown, and many videos are added in the meantime. So I advise you and invite you to come with the YouTube so that you will understand. And this is the thing, doctor, lastly from 24 December. 9 classes is already designed and the doctor already booked their seat. And this is the routine for you again. And know how to fish first, then go for the fishing. And the course highlights are as such. Possibly I discussed it before. I'm not detailing here. So you will learn how to catch almost all exam cases in the shortest possible time. It's very compact and precise courses for you. So this is our message for you, doctor. And of these few words, I like to thank. And again, I don't like to finish by myself one way. So the mic is open for you, doctor. If you want, you can ask me the question. But raising your hand, even you can open your mic. I am actually giving to open the mic. Unmute by yourself. Anyone, please. Any query, any comment, please. Dr. Modi, please.
Sir, how many cases are required to pass the exam? I mean, there are 14 cases as we told.
14.
So, 14. So if we clear 7 cases, we are passed.
It is very variable. Suppose in the 14, you have done bad in the 4 stations. What is your score there? There are some cases or stations, they are vital. If you do bad in the vital, suppose 3 or 4 vital station, but you pass 10, so it will be risky to pass the station. But it is not actually not open. I know this is hidden. The Royal College, the examiner group usually don't disclose it. And especially for acute cases, life-saving issues, doctor should give proper decision. For example, Dr. Modi, thank you. You asked very good question. Suppose a patient of chest pain, you are suspecting myocardial infarction. Patient telling that, doctor, I need to go to the home. I will come back after 2 days. You approved. This is very risky decision. Oh. Your duty to convince the patient to get admitted in the hospital for further evaluation. It is called to be a safe doctor, not a risky doctor. So there is some station like that. So if you do mistake there, actually by counting the station is not enough to pass this exam. This is the concept we gathered until now, doctor, to the best of our knowledge. Any further query, Dr. Modi? Nobody raised the hand after you? Anyone? Other than, feel free, doctor, to ask the question. No one. So, sorry, Dr. Sarah is here. Yeah, please, everyone, please try to keep your hand quickly. I will come one by one, no problem. Dr. Sarah.
Yes, doctor. Thank you for your presentation. I want to ask, doctor, how many months is enough for preparing for OSCE examination and pass for first time, inshallah?
Suppose again, the answer is variable. Those who appeared in the last exam, AKT result in the last 16th December published. I know, I followed. And some of our candidates, I know them, they have passed. We are very happy and congratulate them. Actually, we are not too much open. Everybody I cannot communicate with personally. We wished in the group. So very happy knowing that they passed. But what they will need, again, depends upon. Suppose some colleagues are well oriented in your practice, their knowledge and other. So they may take very few months, maybe 2 months, minimum 2 months needed. I like to say that those who are the scholar, too much intelligent, genius, it is very exceptional. I don't like to comment. My comment is for medium categories, doctor. So minimum 2 months needed. Minimum 2 months. If you can give continuous effort, it will be easier for you. But if you are busy with family work, job and other, so count minimum 4 months, doctor. Count minimum 4 months. Again, if anybody want to practice, suppose I told you, all of you, that you go for the basic courses, basic understanding first, but you don't have time. You have to include your time from your daily life to other courses parallelly. Suppose basic 1 day, practice other session, 1 by 1. Actually, we design in this time for that because a significant number of patients, the candidates actually pass in the AKT as we are running the groups, we are interacting with them. They want to be enrolled, but how to guide them? It is my pleasure, doctor, and grateful to all of you. Those who will be asking me, you get your answer today now, because I cannot give the answer 1 by 1. Suppose you are preparing in the coming March, you have around 3 months time. So I don't like to say that the impossible. I like to say possible. If you are a middle category, you are oriented, and you can give your time in the future 3 months almost every day. So there is a chance. And you need to, if you don't know the basic thing, you discuss with the basic course or others, maybe the video record or the live session, plus practice, maybe in a group or in your friend and together. then there is a chance to get the success in your exam. So time is actually a relative issue, but those are very, very new. Don't know anything. Maybe some of you may have. So minimum take doctor 6 months to 8 months. In the meantime, you continue your practice, you join with the group and other, but 6 to 8 months, please you take 6 to 8 months. Those are very, very new, doctor. It is my practical experience, doctor. My pleasure to share with you. Thank you, doctor, who asked me the question. If no more, I think we can conclude now. And again, to thank you and my gratitude, heartfelt, doctor. And we will be happy if you can be with us for your better preparation and other. Sorry, doctor, I cannot finish. Maybe Dr. Abdul Rahman, please, doctor. Please, anybody have the question? Keep your hand raising, doctor, so that we can save time and finish. Yeah, Dr. Taisir Abdul Rahman, please.
Hello, doctor. Thank you.
Welcome,
for your time. I want just to ask, we need just courses or there is any books to read?
The main book as a reference is Oxford Handbook of General Practitioners. Must and must. Again, yeah. Again, I like to share experience in the last colleagues. A significant number of colleagues actually were with in our touch, and Alhamdulillah, they actually a significant number passed also by percentage, not less. Always we are telling them go through the Oxford Handbook, but they are oriented with some other handmade or other the guidebooks and others. I don't like to discourage these, but guidebook can give you some clues, some technical materials, but the knowledge, messages with a reference, you need to follow a standard book, not to quote from any handmade notes, doctor. Okay. So this book is Oxford Handbook of General Practitioners. Most of the things are there, but structure of the case discussion, what I have shown to you in short possible time, this is the structure. If you practice with them, you get the knowledge from the book, utilize the knowledge in your structured practice. This will be the very brief preparation tips and tricks, doctor. Okay. Any further query? Any further?
Okay, thank you.
Enough? Okay, thank you very much.